Howdy, I'm live. It's Aaron Boster here, and thank you for learning about MS with me. It's been a little while since I jumped online, and I missed you guys, and so I thought, what the hey. I am actually stuck in the Houston airport. I'm going to be spending the night here in a hotel. I missed my connecting flight on my way home from a conference I was attending in Dallas, and so I don't fly out until tomorrow late morning, and I brought my vlogging camera. Hello, Aaron. Hello, AJ's HR. And I missed you guys. I love this growing online global community. And I wanted to reach out, and I thought it would be a great opportunity to talk to everyone. Hello, Francis. I hope you're doing well. Love hearing you from Texas and from India. I've got folks from Louisville, Kentucky. Hoorah. As many of you know, please, when you jump online, tell me where you're calling in from. I love seeing this global group of people band together as a village, as a virtual village, talking about MS and supporting one another. There's a lot of love. I've got folks from Canada, from Delaware. I've got folks from Vernon, BC. That's very cool. Yep. So I was in Dallas attending a weekend conference. It was a really great conference. We talked a lot about MS therapeutics, specifically talking about the new entrants into the market. I learned a lot this weekend. I was supposed to be home by 11 o'clock tonight, and that's not going to work out. But I've got my vlogging camera, and I am online with you guys, and that feels fantastic. Now, I'm not sure exactly how we're going to play this tonight. I would like to entertain some questions. And so I've got a bank of questions, of course, that I've saved from the last time that I was online. I'm going to pull some of those up right now. And I'd also like to take some of your questions live. So there's a couple thumbs up. You guys know I love it when you throw me some love with some thumbs up, so let me know. Board Again Farm Girl, hello, how are you doing? Janine, how are you doing? Aaron, how are you doing? Karen Tweed, what's going on from Winnipeg, Canada? A lot of great people jumping online tonight. There's already 46 of you. So, I'm going to start with some of these questions that people had prepared for me from the last live stream. And as I've shared with you before, it's kind of hard sometimes to be able to read the scrolling live stream and to answer questions. And so it's more easy for me if you list your questions, I record them, and in my next live stream, I answer them. And so I'm going to try to do a combination of the two. I've got a question here that was sent out last time from an anonymous person. An anonymous person wrote the following: Dr. Boster, I'm an MS patient and I'm so appreciative of your channel. Well, anonymous person, that's why I created this channel. It's for people impacted by MS, so that rocks. Anonymous person writes, I keep my diagnosis hidden and I'm only allowed to see my doctor once a year, where I hardly ever get any type of education on MS. All of your videos are great. I've learned so much about MS. So, anonymous person, that kind of breaks my heart. Having MS is super challenging. Having a progressive neurodegenerative condition, having an inflammatory neurological condition is tough enough. But to not share that with anyone makes me so sad inside. And first off, I want to say, anonymous person, you are not alone. The people here in this virtual village are here to support you. I am here to support you. And I want to ask you to please contemplate, please consider letting someone that you love know that you have this condition. It's not something to be shameful about. It's not something to hide. And to grapple with this disease is hard enough. But to do it without letting others know, that just makes me super sad. So I wish you the very, very best. And it's my hope that you'll consider letting someone in. So let me know what you think about that, guys. If you agree with me, or even if you don't agree with me, leave a comment below. But it's my strong opinion that you need the biggest village possible. And if your village is only 1 or 2 people, okay. Those are key villagers. But I want you to have somebody. So great question. Thank you. Maybe what I'll do tonight is I'll do a question that I've saved, and then I'll do a live question. So let's see if I can pull that off. Karen Tenenbaum writes in today, and Karen says, what do you think about the new MS drug approved by the FDA? So, Karen, last week was a revolutionary week, probably a week that will never happen again, because there wasn't one, there was actually two drugs approved by the American FDA for MS. The first one is siponimod. Mayzent is the trade name. And the second one is cladribine, and that's Mavenclad. And so I spent the majority of today reviewing the package inserts in a group of MS neurologists and kind of discussing them. And Karen, if you check out my last live stream, I have a dedicated video where I talk a lot about those drugs. I'm very opinionated, and on this channel, sometimes I'll share with you my opinions. And before I say anything, I want to let you know that just because I'm opinionated doesn't make me right. It just makes me opinionated. And you have to work with your MS provider to know what's the best drug for you. Now, Mavenclad, cladribine, and Mayzent, siponimod are very different drugs. And I'll just say a few words about them. And again, these are my opinions. Now, I fully plan to do an entire video on each one of those drugs. And that'll probably be in the next few weeks. It's going to take me a little while to put all of that together. But just to say a few words, Mayzent, siponimod, is a Gilenya Me Too drug. So Gilenya is a pill. It was actually the first pill for MS, and it was FDA approved in October 2010. It's a pill which is a moderately effective drug. That's Gilenya. It's got really solid, good efficacy. It's not the very, very best. I don't think that Gilenya is better than the monoclonal antibodies, than the infusible drugs, but I most certainly think it's probably amongst the very best pills, and it beats the pants off, in my opinion, of a lot of the injections. Now, Mayzent, or siponimod, is a Gilenya Me Too. It's a derivative of Gilenya. It's a bit more selective, and there are some things about that that I'm going to focus on today. The efficacy of Mayzent isn't different than Gilenya, in my opinion. And so I think that Mayzent, siponimod, gives you mid-range efficacy, which is pretty solid. The safety profile is different. And one of the big differences between Mayzent, siponimod, and the parent compound, Gilenya, is that Gilenya requires a first dose monitoring. So when you take Gilenya, the very first day you take it, you have to get an EKG ahead of time. You take the pill, and then we have to observe you for a 6-hour period, which is kind of annoying. And each hour we have to check your heart rate and your vital signs. And then at the end of the 6 hours, we check a second EKG. And the reason is that there's about a 20% drop in your heart rate when you take Gilenya the first time. Literally, it's a first dose phenomenon when you take Gilenya. Now, Mayzent is a bit different. It's missing one of the receptor sites as compared to Gilenya, the P3 receptor. And we think that therefore it binds less to the heart and it has less cardiovascular side effects. And so unless you have certain cardiovascular risk factors, history of stroke or heart attack or a couple other different things that would place you at risk, people taking Mayzent don't need a first dose monitoring, which is really great. Now, the way that in part they sorted that out is by doing a titration where you ramp up the drug. You take one pill, and then you slowly ramp up the drug by taking increasingly higher dose over several days. And this mitigates largely having to do a first dose monitoring. And this is good, but it also has some baggage along with it. Mayzent stays around a lot less time in the human body. You clear it faster. And so if you miss 4 days of Mayzent, you're going to need to go through that titration again. I practice MS in the real world, where real people take real medicines, and they do things like they forget their medicines over a long weekend. This happens. It doesn't make someone dumb or bad. It's just something that happens. And so one of my concerns is that if you went off of it for 4 days and then you said, oh man, I forgot my medicine, and you start back without doing the titration, you could find yourself in harm's way. And so that's just something that came out that I really sort of thought about today for a while. And it's something that I'll bring to your guys' attention. But largely, I think that Mayzent is going to be the same efficacy as Gilenya. And the label and where it's used really is with relapsing forms of MS, just like Gilenya. The label's written a little differently. Interestingly, it's approved for clinically isolated syndrome, so after the first attack. Mayzent is approved for relapsing forms of MS. And it's also approved for secondary progressive MS with activity, with attacks. And so that's all I'm going to say about that drug today. If you want to hear a bit more about the efficacy and some of the details, you can certainly check out my last live stream, or just wait a week or two and I'll put out a formal video where I'll discuss that in some depth. So Karen, the second drug that was FDA approved last week is called cladribine. And cladribine, which the trade name is now Mavenclad, is an interesting molecule. It's got an interesting history. When you go back to 2009, so a while back, we thought that cladribine was going to be the first FDA-approved pill for MS. I was a sub-investigator for a trial called the Clarity trial. And when Mavenclad was presented to the FDA and to the EMA, the answer was no. There was a refusal to file. And they had some concerns with safety, specifically about cancer. And so it wasn't approved. There was a complete failure to file. Sorry, I'm in this weird hotel room, and I can hear someone through that door. So hopefully I'm not bothering them by talking too loudly. Now, several years went by. I mean, again, this was 2009, guys. And several years went by, and they sort of ended all the Clarity trials. It was sort of a thought, it was something of the past. And it's been revitalized. And there was an attempt to do a long-term follow-up where they went and they tried to call all the patients they could get a hold of. They got a hold of maybe about half of them. And so we really don't have long-term follow-up data on Mavenclad. We don't have a prospective study that's gone since 2009 all the way to 2019. We have 2 years of data from the Clarity trial. And nonetheless, the makers of Mavenclad presented it to the EMA and it was approved. And they presented it to the FDA and it was approved. And so Mavenclad is an interesting medicine. It's a medicine that you take a pill or two a day for 4 to 5 days in a row, and then you do nothing for the rest of the month. So that makes me sort of feel like it's like a reverse birth control pill, because you only take 5 days and then nothing for the rest of that month. Then you take another 4 to 5 days, and then you're done for that year. And so that's very unusual. Mayzent is a daily pill like Gilenya, and Mavenclad is discontinuous. You take 5 days, wait a month, 5 days, then you're done for the year. And then in the second year, you repeat that process. And so that's rather interesting. But there's something in the label that I realized today that really struck me. There's some concern about a cancer risk with this drug. And the American label says, after you've had the 2 years worth of dosing, you can't have any more Mavenclad for 2 years after that, because to give the 2 doses the way I described and then give more apparently would increase that cancer risk. And this creates a major concern for me. So imagine, if you will, that you take Mavenclad, you do the 5 days, wait a month, 5 days, then a year later you repeat that process. And then, God forbid, you suffer an MS attack. Well, in my clinic, I would be concerned that you had breakthrough disease, and I would be inclined to redose you, to give you more drug, or to switch your drug to escalate it to something more effective. But the FDA has stated no. They've said that you can't redose for a period of 2 years. And their concern is because of immunosuppression and cancer risk. And if they're concerned about cancer risk, that means to me that stacking other immunosuppressant medicines, some of these really oomphy medicines like, Ocrevus or Lemtrada, or even something maybe like Gilenya, might not be acceptable. That also might increase the cancer risk. And so I have to grapple with this. I have to try to figure this out. Because if the only option, if you have a breakthrough on Mavenclad, is to consider a immunomodulator like the first-line injections, that's kind of a concern of mine. So, Karen, that was a long-winded explanation. I hope that it brought some clarity to these 2 drugs that have recently been FDA approved. If you'd like to hear a bit more about them, I certainly talked about some of the top line efficacy in my last live stream. And as I mentioned, I plan to do full videos on both of them in the next couple weeks. So there are 89 people that have jumped online. That warms my heart. It makes me feel awesome. Thank you guys. For those of you that are just jumping online, I'm trapped in a hotel stuck in Houston, Texas overnight. And I missed you guys and wanted to say hello, howdy, hi. So there's 42 thumbs up. If you're digging what we're doing, give me another thumbs up. And now that I've answered a live stream question, I'm going to go and answer a question that I recorded from last time. So this is a good question. So this is a question that was asked before by a viewer named Michael Murphy. And Michael Murphy writes, could you look at my results for a second opinion? Thank you. So Michael, the answer is no, I can't do that. But I want to explain a little bit about this. I'm a doctor. I'm a neurologist. I'm an MS specialist. I work in Columbus, Ohio at a really cool place called Ohio Health, where I participate in a large comprehensive MS center. We see, probably about 18, almost 20 new patients each week. Not me, but my team. I work with a bunch of amazing doctors and nurse practitioners and a bunch of other really fantastic people that are all geared towards MS and making people with MS the most awesome version of them. I don't have an easy mechanism where you can mail me your records and I can look at them and then I can give you a second opinion. I would like to be able to do that. That's called a virtual consultation, and it's not something that we've figured out how to do just yet. So, Michael, unfortunately, I'm not able to do that at present. It's something that maybe one day we will be able to do. And in the same fashion that right now I'm doing this live stream, it wouldn't be too complex in a future state to do virtual visits where maybe I would do a virtual consultation like this. But in 2019, April, I don't have that capacity. I do see new patients every week. And so if you're willing to take a plane to visit Columbus, Ohio, we would love to see you. But I can't review your records and then give you some info. I might as well piggyback off that and share another thing. I love reading your guys' comments. I genuinely enjoy interacting with you. I love reading your questions and your own life experiences with MS and how you thrive and survive. But I can't diagnose you or give you medical advice on the interwebs. So when you write in and say, Dr. B, what about this? What do you think I should do here? It's not enough information. When I see a new patient in consultation, they submit their MRIs and I look at all of them, and they submit their records and I look at all of them. And then they come in and they go through some intake work, which takes about a half an hour of answering patient-reported questionnaires and going through some very formalized testing before I see them. And then I spend an hour and a half in the room with them where we take a very careful history. I do a full neurological examination. And after that, we can start to uncover what's going on. So clearly, you writing a question and telling me 5 or 6 lines about your story isn't enough information for me to do a proper job sharing with you my thoughts and opinions. And so I share this with you guys out of respect because I don't want to not answer you. It's not that I'm trying to be rude. It's that I can't practice my craft when you send me a paragraph. So keep in mind that when you send me a question, it needs to be sort of a generalized question, something where I can give you some info and some medical education, but not so much medical advice. So let's jump in and see about some other questions that are from the live stream. So let's see here. Here's a good one. So MS Geek writes in, Dr. B, what are some over-the-counter supplements that you generally suggest for your RRMS patients? Well, hello, MS Geek. I hope you're doing well, and thank you for the nice question. And let's talk over-the-counter supplements. Now, I think it is reasonable for all adult humans to take a multivitamin. So I would recommend that all of us take a multivitamin. If you ate like awesome and you ate lots of fruits and vegetables, you may not need a multivitamin, but many of us might miss out on some green stuff each day. And so I don't think it's unreasonable to take a 1-a-day multivitamin. So that's the first one. If you have multiple sclerosis, I'm of the opinion that it's best to have an elevated level of vitamin D. And so we at our center at Ohio Health, we check your vitamin D level. And if your vitamin D level is low, we supplement your vitamin D with D3. Now, MS Geek, don't run out to the pharmacy and buy a bunch of vitamin D3 and eat it all. We we gauge how much vitamin D to give you based on your blood level. So if your level is 10, or if your level is 30, or if your level is 40, we're going to give you different amounts of vitamin D3. And it's D3 that we give, not D2, because D3 is better absorbed in the human body. So many people with MS, where I live in the Midwest, don't have exposure to the sun all year round. And we get natural vitamin D through our skin through the sun. And so we give them a supplement. So I would say a multivitamin, and many people take D3. Now, that's the majority of what I would recommend for over-the-counter supplements. In specific circumstances, we might supplement other things. I do not recommend taking, for example, B12 unless you have a B12 deficiency. But there are a couple other supplements that I'll go over with you right now. Again, please do not run to the pharmacy and buy this stuff. These are things that you must talk to your MS provider about and make sure that they're right for you. So one of them is biotin. So biotin is a vitamin, B7. And you can buy over-the-counter biotin. It comes in 3 milligrams, and it's supposed to be really great for improving your nails and your hair. So obviously, guys, I don't take biotin because I don't have a lot of hair. But there's a couple of really cool studies done in MS. And I've talked about this before, where they gave 300 milligrams, not 3, but 300 milligrams of biotin. And in primary progressive MS, there's a study that suggested it slowed progression, which is really, really cool. There's a separate study that suggested that it slowed brain shrinkage in PPMS. And so in some patients, we give them high-dose biotin, ultra-high dose, 300 milligrams. And you should not take high-dose biotin without talking to your doctor. And if you take high-dose biotin, there's an important caveat. So please listen to what I'm about to say. Biotin, I fogged up the camera. Sorry, guys. Well, hello. I'm not going to do that again. Sorry. High-dose biotin can alter lab results. It's not that you have an abnormality. It's that the biotin in your blood changes the lab test. And so there are certain laboratories like thyroid testing and hepatitis B testing, even some cardiac testing can have a changed result if you're on biotin. So if you take high-dose biotin, it's imperative that you stop the high-dose biotin about 3 days to a week before you have any lab tests. Otherwise, you risk coming back with what we call it spurious or fake results, and it can be super confusing. Both my partners and I have all had experiences where we forgot someone was on high-dose biotin, and we got a lab back and said, oh my goodness, their thyroid is wacky, or oh no, they have hepatitis B and they don't. And so that's a caveat that's important to remember when it relates to taking high-dose biotin. What's another supplement? So when people with MS have fatigue, and this is the most common symptom in MS, pathologic fatigue, we do lots of different things to try to combat fatigue. I have an entire playlist of I don't know how many videos talking about how to combat MS fatigue. And there's a multitude of things we do, from removing naughty drugs to exercising to using naps. There's a lot of things. And there are some medicines that can help with fatigue. So there's an over-the-counter supplement that some people with MS really benefit from as it relates to fatigue, and that's levocarnitine, or L-carnitor. And this is an amino acid, and a dose of 1 gram twice a day was shown in a clinical trial, actually 2 clinical trials, to help with fatigue in some people with MS. Now, do not go to the pharmacy and buy levocarnitine and start taking it. You have to talk to your MS provider or your MS clinician before you start to do this stuff. And that's important to me. I'm not trying to tell you to run out and buy a bunch of vitamins. But what I am sharing is some medical education that high-dose levocarnitine, 1 gram twice a day in some MS patients, helps with energy levels quite a bit. The list goes on. There are very small studies that look at alpha lipoic acid and a host of other things. But the ones that I've mentioned are the ones that we most commonly recommend. So I hope that helps answer your question. I really appreciate it. I also appreciate that there's 65 thumbs up. So thank you guys for the love. There's 104 people online. We've been rocking and rolling now for 24 minutes. And so let me go to my bank of questions here, and I'll grab another one. And so let's take a look at this question. This is a good one. So this was a question from the last live stream. And let me pull it up here. And it was asked by Liam C. So Liam C wrote in and said, "Hi, Dr. Boster." Well, hello, Liam. If someone responds well to Lemtrada in their early 30s, what does their future disease progression look like in your opinion? So Liam's talking about using one of the more effective medicines, Lemtrada. The real name is alemtuzumab, and I have a lot of videos on alemtuzumab. I think Lemtrada is one of the most effective medicines that's available for MS. I also think it's one of the most complicated and most challenging to use. And Liam's asking, if you take it when you're young, because I think 30 is on the young side, and you have a good response, well, then what are the expectations moving forward for future disease? Well, Liam, we have 8 years of long-term follow-up data from the phase 3 trials. And I'm talking about trials that are called the CARE-MS1 and the CARE-MS2. And this is really great data that we've collected prospectively, meaning people with MS entered the trials, and after 2 years, they entered a long-term extension where they were followed prospectively. We never stopped following them, and we've gone out 8 years. And I can share with you 8-year data, which is maybe not exactly what you're asking, because I think that your question really is talking about long-term. But let me go over the 8-year data with you. At 8 years, about 55% of people, so over 50% of people, never got redosed, which means they never had an attack or they never had new spots on their MRI. It's pretty awesome. 30% required another course. So they got their first 5 days, and then a year later, they got their 3 days. That's the first and second course that everyone gets. 30% of people over the next 6 years, they needed a third course. So 55% didn't need any more, 30% needed a third course, and about 12% needed a fourth course. And when I look at the 8-year data, I'm very, very impressed with this drug. Each year, about half of people had NEDA, no evidence of disease activity. And at 8 years, about 77% of people had stable or improved exams. So, Liam, I can't comment on what happens 20 years down the line, but I certainly think that Lemtrada is a provocative drug. And if you've responded well in your 30s, I would hypothesize that you've changed the trajectory of your MS. I would hypothesize that you've changed the long-term outcome of your MS for the better. I love the fact that there's this ongoing long-term follow-up. Next year, we'll have 9-year data, then we'll have 10-year data, and it will continue to grow. And so that's kind of exciting. And let me share with you guys a term that I've been thinking a lot about. I did a video on this, but I want to talk about it with you right now. And that's a very, very charged term. It's a very charged word. And that word is remission. Now, I'm not talking about relapsing remitting MS. That's an old term, and I dislike it. I really dislike the term relapsing remitting MS because it makes it sound like if you're not having a relapse, then you're in remission, which is not true. I don't even call it relapsing remitting MS anymore. I call it relapsing MS. I drop the remitting because I think it's a misnomer. Now, when I say the word remission, I'm talking about the oncology, the cancer definition of remission. The cancer definition of remission is as follows: 5 years with no discernible disease activity in the absence of treatment. And that's the cancer definition of remission. Well, Liam, I just told you that at 8 years, about 55% of people never got redosed, which means they meet that definition of remission. And it is a very emotional and charged thing for me to share that with you. I never ever thought in my life as an MS neurologist that I would ever talk about remission with people with MS. I didn't think that was going to be a possibility, and that's actually a possibility for people now. I'm very excited about that, and I hope that you are too. So let's now go to the live stream and look at some other questions. So I'm scrolling along trying to find one. Oh, and here's Delaney. Hey, Delaney, I hope you're doing well. Delaney, I have a special surprise for you. because I just did a video I recorded yesterday where I answered one of your questions. And so I'll put that out sometime in the next couple weeks, and I hope that you like it. But you're asking a question right now. So let me read what you got going on. Delaney writes in and she says, Dr. B, when I ask if you had MS and how you would fight it emotionally, mentally, and physically, I mean, other than the 4 for 4, like what would be your average day look like, especially bad ones? Wow. So that is a serious question. So Delaney, I don't have multiple sclerosis. I had a family member with MS, and many of you have heard the story about how I got into MS because of my family member with MS and me at a young age watching him deteriorate and watching the doctors not do the best of jobs and me wanting to do better. So I don't have multiple sclerosis. And the reality is, Delaney, I can't tell you how I would be because I'm not in your shoes. I don't have the condition, and I don't want to presume to be able to tell you. But there are some things that maybe I can convey. And obviously, I'm a proponent of being 4 for 4. So if I had MS, there's a couple things that I would want to do. Number one, I would want to use, hands down, the most effective medicine as early as possible. I'm a really big believer in this. I talk about this a lot. It is a tenet of mine. If I had MS, I would give myself the single most effective medicine that I possibly could get a hold of as early as possible, because it's my belief that that helps change the trajectory of the disease long term. So that's one thing. I would be very into exercising as part of my lifestyle. And I have seen time and time again over the last decade and a half, people with MS that dedicate themselves to exercising as part of their lifestyle, they do better. I mean, they do better long term. They have a slower disease trajectory. They also have a better quality of life. They sleep better. They have better energy. They have less cognitive fatigue. It's a big deal. It is so exciting for me when a patient of mine finally embraces exercise and they come back and see me and they're like, wow, because suddenly they have more energy and they do better. They have a better quality of life. And so if I had MS, that's definitely something that I would want to embrace. I would not smoke cigarettes. You know this. I talk about this a lot on my channel, that smoking cigarettes speeds up MS. But in addition, I would pay very close attention to other cardiovascular risk factors, avoiding morbid obesity. God forbid, if I had diabetes, I would want to treat the hay out of it, making sure that I dealt with my cholesterol. I actually have high cholesterol, and I take a cholesterol medicine, and I wouldn't stop that if I had MS because I would want to lower my cholesterol. I would want to treat high blood pressure because high blood pressure can drive the disease faster. And then the last thing, Delaney, is talking about diet. And, this is my 4 for 4 concept, but paying attention to diet is important. I have a couple of videos on my channel where I talk about using a cardiovascular diet. I have a video where I talk about avoiding processed foods, and these are things that I believe in. I don't know that I can say much more than that, Delaney, because I don't want to pretend to put myself in the shoes of someone with MS. And so out of respect to you, that's about as far as I can answer this question. It's great to see you online, and thank you very much for that provocative question. So now I'm going to jump in and find another question from the last live stream, and I'm going to tackle that one. So what do we got going on? Oh, here's a good one. This is a great question for a Saturday night. And so this was a question that was asked at the last live stream by Miss Sharon, 09. And so Miss Sharon writes in and says, hi, I am a 37-year-old woman who suffers from MS. I have lesions on my brain and in my spine. One symptom that is causing issues in my marriage is the fact that I do not have a desire for sex or intimacy. What can I do to make this situation better? Please help. So Ms. Sharon, number one, thank you for your willingness to talk about this. Thank you for your willingness to write that question, because many adults are embarrassed about talking about the down there's. They're embarrassed about talking about sex and intimacy. And many people with MS have difficulties. Not everybody, but many people with MS have low libidos. They have pain with intercourse, or they have difficulty with intercourse. And guys, if you're nervous or turned off by sexual comments, then leave the live stream right now, because I'm going to say words like lubrication and erection. So if that offends you, I'm sorry, and so you want to get off the live stream. So I'll give you a second to leave the live stream, and nobody's left. So there's 122 of you online. So let's talk a little bit about that. It is not uncommon that women with MS can have difficulty with libido, with sexual desire. They can have difficulty with vaginal lubrication. They can have difficulty achieving orgasm. It is not uncommon that men with MS can develop difficulties with low libido, low sexual drive. They can have difficulties with erectile function, either obtaining an erection, maintaining an erection, or ejaculating. Now, as an adult, sex is a major quality of life issue. And having impaired sexual function is horrible. And so I like to discuss with my patients the fact that I am open to discussing sexual impairment, because it's important for quality of life and it's treatable. We can treat sexual dysfunction. So let's talk a little bit about sexual dysfunction. And again, I hope that I'm not offending people by talking about this topic, but Ms. Sharon asked about it. And I suspect that maybe several of you that are listening and might want to hear a little bit about it. So there's 3 kinds of sexual dysfunction in MS: primary, secondary, and tertiary. So primary sexual dysfunction involves damage to the neural structures that are involved in the sexual response. So Ms. Sharon says that she has spinal cord lesions, and it's not uncommon that spinal cord lesions can be associated with sexual dysfunction. So quite literally, the circuitry of sex is impacted. Secondary sexual dysfunction isn't that the circuitry of sex is impaired, but symptoms of MS impair sexual function. So for example, if you're really profoundly depressed, it can depress sexual function. If you have spasticity, so you're engaging in intercourse and your leg goes into a spasm and you have a Charlie horse, well, you have to stop having sex because that's super painful. If you have neuropathic pain and when someone touches your skin, it hurts you, that makes it really hard to have sex. So that's secondary sexual dysfunction. Tertiary sexual dysfunction is when a human being with a chronic illness just doesn't feel very sexy. They kind of feel ill. They don't feel like a sexual person. And so we have to deal with all 3 of those. And I'm going to talk a little bit about things that we can do. So first off, we need to look at the medication list and see if there are medicines that the doctor's giving you that can impair sexual function. And a great example are antidepressants. So the most common class of antidepressants are SSRIs. These are medications like Prozac and Zoloft, and these are really great medicines, but sometimes they can impair sexual function. Many of you know that my preferred antidepressant is Wellbutrin. And the reason I like Wellbutrin, amongst other things, is it doesn't impair sexual function. And so looking carefully at the medication list and removing naughty medicines is one thing. The second thing that we can do is we can make sure that we're treating fatigue and depression. We can make sure that we're treating neuropathic pain and spasticity. In other words, we can tackle the secondary sexual dysfunction issues. If you have neuropathic pain, or you have bladder incontinence, or you're horribly constipated, these are all things that can massively impair sexual function. And so we can treat those things to help in the bedroom. What else can we do? I'm going to teach you guys the vibrator trick. I have videos on sexual function. I have an entire playlist on my channel called Drug, Sex, and Multiple Sclerosis. And so a lot of what I'm talking about, I go into some depth in those videos. But I want to talk to you about the vibrator trick really quickly, and then I'll stop talking about sex, guys. So right now, as I'm live streaming with you, I'm using my indoor voice. I'm not yelling. I'm not screaming. I'm talking at a normal voice. Now, but let's pretend that I was trying to talk to you and there were 50 people in the room. Well, there would be so much extra noise that I would have to scream so that you could hear me. I would have to raise my voice because there would be interference between my mouth and your ear. And so I would have to raise the level of intensity so that you can hear me. If you have primary sexual dysfunction from MS, you have lesions in the spinal cord. When you have the down there stimulated, there has to go a message, a neural message that goes from the down theres, from your groin, up your spinal cord into your brain so that your brain can learn what's supposed to be happening. Then your brain has to send a message all the way back down your spinal cord, down the down there's, so that you can have adequate vaginal lubrication, or so that the gentleman can have an erection, all this stuff. And sometimes when there's spinal cord damage from MS, the sexual message literally dies along the way. It doesn't get there. And so that can be a major impairment to sexual function. So in the same way that I might have to scream so that you can hear me if there's interference, we can provide what I refer to as overdrive stimulation. Overdrive stimulation so that the brain can learn what's going on down there. So how do you do that? Number one, water-based lubricant. Number two, plug-in-the-wall vibrator. Now, this is a trick that works for both men and women. And after several men said, "Hey, doc, I stole my wife's vibrator and I was able to maintain an erection," I now recommend this to people. And so a plug-in-the-wall vibrator is important because you need really serious intensity, not this double D battery kind of thing. And a water-based lubricant increases skin sensitivity. So here's the deal. Apply a water-based lubricant to the down there's, and then use the plug-in-the-wall vibrator. Men, you can do this. Women, you can do this. And what you'll find is a lot of times the overdrive stimulation gives enough input that the message gets up to the brain so that you know what's going on. I have a lot of men and women come back to me and say, that really helped out a lot. And so that's what I call the vibrator trick. And I've certainly talked a lot about sexual function. Again, it's not my hope to make you feel uncomfortable, but quality of life is really important to me. And as an adult, I think that sexual function is something that's really important. So Ms. Sharon, I hope that helped answer your question. I've been online for 41 minutes. I've got 80 thumbs up. Thank you guys. I love this love. There's 123 of you online. And so now let me answer another question from the live stream that people have posted today. All right. So here is a question from Mary Lou Clement. Mary Lou Clement just wrote in and said, Dr. B, is there any way a woman with MS can determine when a symptom is due to her MS or due to perimenopausal or menopausal, since some of the symptoms can apply to both? Well, Mary Lou, you're absolutely right. And when a woman goes through menopause and the ovaries are shutting down and the estrogen levels are falling, they can have some symptoms from that. And interestingly, there's a couple papers that suggest that when a woman goes through menopause, you can see an uptick in her neurosymptoms. Her neurological symptoms from MS can actually intensify in the setting of menopause. And so that's the first thing that I think is important to talk about. Now, if you are suspecting that you're going through menopause or perimenopausal, maybe the menstrual cycles are irregular, or there's other things that might tell you hot flashes and whatnot, I really recommend that we partner with the obstetrician or the gynecologist. I would want to work with the gynecologist or with your primary care doctor. There's some hormonal testing that can be done. And then we can talk together and figure out if we need to do some supplementation, or if we can address the menopause or the perimenopausal symptoms, because those are things that we can oftentimes treat. It is challenging to sort out one from the other. And I don't think that we necessarily need to sort them out. I think that we need to manage the menopause as best that we can. Now, as an MS neurologist, I don't feel that's something that I have great expertise in. And so I am grateful for my colleagues that are gynecologists and for my primary care colleagues that can help guide us through that process. It takes a village, and sometimes those villagers include a lot of doctors. Okay, so let me jump into a question from before. And this is a question that I was looking forward to answering. So this is a question from the last live stream. And it was written by a viewer, Julia Gabriella, and I'm going to not say the last name correctly, Cludera. So Julia, I hope I didn't butcher your last name. And so Julia says, I don't even know how to access other videos. So this is a live stream on YouTube, and this is my YouTube channel. And so just to share with you, I have, 250 almost videos that I've done, and I've placed them all into playlists. So if you go to the YouTube channel and you look up at the top, you'll see it where it says video, playlist, community. And if you click playlist, there's, I think, 30 some playlists that I've made. I have playlists on fatigue, playlists on various drugs, playlists on treatment philosophy, playlists on cognition. And you can click the playlist button and it'll show you a list of those videos. So Gabriella, or Julia Gabriella, I would encourage you to take a look at that. I try to the very best I can to catalog those videos so that people can go back and look at them. As many of you know, I created this entire YouTube channel for my own clinic patients. And it's my goal that through these videos and through these live streams, I can help educate, empower, and energize my patients in between visits. If you think about it, if we see patients at my center 2 to 4 times a year, that's not enough to teach you about a chronic condition. I really believe that. If I was trying to teach you how to play the game chess and we only met every 3 months, you wouldn't be very good at chess. So how am I supposed to really up your MS game if I only see you infrequently? Hence the desire for this channel. And what I've now realized and what I now think is super awesome is that it doesn't just apply to my own patients. It applies to this entire global village. And it's my hope that through my videos and live streams, I can reach out and help educate as many people impacted as MS by possible. And the playlists are intended to be a library. So if you have a question about sexual function, like Ms. Sharon did, or if you have a question about fatigue, like we had earlier today, you can go to the playlist and look at that. So Julia Gabriella, I hope that helps answer your question. All right, 45 minutes online. There's 120 people online. There's 93 thumbs up. Thank you guys. I love this love and I love this growing online community. Here's a question from Jaden Z. So this is a live stream question being asked right now. And Jaden Z writes, I was diagnosed at 18 with MS 4 days ago. Wow. So Jaden, thank you for sharing that with me. And welcome to this global online community. Welcome to this village. I hope that you find a home here and that you find a group of people that care about you here and that are going to be here to support you. So hello, Jaden, and welcome. So Jaden writes, I was told that I had JC virus and that it's very common, but in extremely rare cases, less than 1% can cause PML due to medication. Should I be worried? All right, solid question. Now, Jaden, I have videos on the JC virus on PML, which is the infection that can be caused by the JC virus. And you're going to find most of those videos associated with Tysabri. So I want you to go and check out those videos, but I'll talk a little bit about it right now. The JC virus is a virus that about half of people have. So it's not uncommon that people have JC virus. And in normal circumstances, the JC virus doesn't bother us. We can handle beating up on the JC virus, no big deal. But there are certain situations, like certain types of cancers and certain medications that can create a situation where the JC virus can mutate and it can go in the brain and cause a very serious infection called PML. That infection can be fatal. And there's one MS medicine in particular called Tysabri, natalizumab. And if you take Tysabri and you're JC virus positive, there's a very small risk. And you said that, less than 1%, a very small risk of PML. Now, I have a particular philosophy about this. I'm not going to get into the details right now. And there are other medicines in MS where we've seen rare cases of PML, but it's most commonly associated with Tysabri. And there are 18 approved medicines now to treat MS. I'm of the opinion that everything is a risk benefit. And I'm of the opinion that the answer is not no, you can never have one of these drugs if you're JC virus positive. I don't believe that. I think that we have to look at the statistics. And so to speak to your question, Jaden, if we calculated your risk, let's say, and with a certain JC virus number and a certain number of Tysabri infusions, let's just pretend that your risk was 0.01%. Well, I'm not allowed to tell you that that's okay with you. I'm not allowed to tell you it's not okay with you. I think instead I have to explain to you what 0.01% means. So you take $1, turn it to 100 pennies. You take a penny, cut it into 100 pieces. One sliver is 1/100%. And I have to explain to you what PML is. PML is an infection that goes in the brain. It actually causes demyelination. About 20% of people die, which is horrible. About 20% of people are able to go back to work. And the remainder of people develop neurological disabilities. So this is nothing to joke about. Then I need to listen to you, Jaden, about how you feel about that. And I have some patients that say, whoa, 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 I am not comfortable. And if you're not comfortable with that risk of 1/100%, then we don't give you that drug. If you say 1/100%, I'm okay with that, and you understand what I'm saying, then I don't take it away from you because I don't feel that it's my right to be paternal. Now, Jaden, I hope this helps. And if you want to hear more about this, please go check out my videos that talk about the JC virus, PML, and Tysabri. Also, Jaden, I have a couple of videos on my channel for newly diagnosed patients. And again, if you go to the front, the very front of my YouTube channel, there's the premiere video, or the video that shows up in the front is actually a message that I made right before Christmas to patients newly diagnosed with MS. And so I would ask you to check that out. This has been fantastic, guys. I love this online community. Thank you very much for spending some time with me tonight. As I shared with you when I started the live stream tonight, I'm stuck in Houston, Texas. My plane got delayed, and I'm not going to be able to fly out until tomorrow morning. And so I am really appreciative of all of you for spending a Saturday night with me. I'm going to log off and get ready for bed. And before I go, I want to say thank you again. I want to say thank you to the people that watch my videos. We are almost at 10,000 subscribers. That's unbelievable. I never ever thought that I would have a YouTube channel, and I never thought that we would have 10,000 subscribers. So we're really, really close. If some of you online right now haven't subscribed to the channel, click that subscribe button. Please hit that little red button and let's get that up there, because we're really, really close to 10,000 subscribers. And I want to thank you for that. I also want to thank the folks that participate in these live streams and the people that leave comments and questions, because I'm so appreciative for that love. So thank you. I have been putting out about a video once a week. I actually put out a video this morning. So if you haven't checked that one out, please go do that. And until my next live stream or my next video, this is Aaron Boster saying thank you for learning about MS with me, and have a great night and take care. Thanks, guys. Bye-bye.